Welcome to the Red Clinic Podcast. I'm Dr. Schwalen, licensed psychologist and expert in the treatment of eating disorders. Today, we're going to do what we do best. We actually started a series. The last several episodes that I have recorded have to do with all the different types of diagnoses of eating disorders. And each week, I've been covering a different diagnosis. So up until today, I have reviewed with you what anorexia nervosa is, bulimia nervosa, atypical anorexia, and binge eating disorder. So today's episode, we're going to talk about avoidant restrictive food intake disorder. And the acronym for that is ARFID. And so I'll refer to it as ARFID throughout today's conversation. But I just want you all to know out there that this is just a really fancy way of saying picky eating. And I say that a lot too. So ARFID or picky eating, I'm going to be talking about the actual disorder today. I will do exactly what I've done so far. I'll give you what the DSM says about the disorder. So basically it's our big fancy diagnostic manual that, doctors and physicians and psychologists and psychiatrists all take a look at. To determine what someone is going through and whether or not it meets criteria for a certain disorder. And then I'll give you some real life examples of what it actually looks like, in a practical way, because just, the textbook version of it doesn't always match the real life version of it. And so talking that out can be super helpful and important. All right, so let's talk about what ARFID is. The different thing about ARFID is that it doesn't have anything to do with a fear of weight gain or any kind of body image problems. So there's not really any body dissatisfaction associated with it. Sometimes there can be. Boys especially might say, I wish I was bulkier or I wish I looked stronger, and that does bother me. But it has a different flavor to it or a different flair on it than what body dissatisfaction can seem like with the other disorders. With anorexia, with bulimia, even with binge eating disorder and atypical anorexia, we usually see, a fear of weight gain. We see immense body dissatisfaction and over focus on the way one looks. We don't normally see that as often with ARFID. The DSM basically defines ARFID as an eating or feeding disturbance. So it goes on to further specify it as an apparent lack of interest in eating or food, and then avoidance based on a whole bunch of different things. And so I'm going to actually take you through what those things look like. There's about 4 different reasons why people would avoid food if they have ARFID. And so I'll talk about that here in just a minute. But overall, in order to meet criteria for ARFID, someone needs to persistently fail to meet their appropriate nutritional and or energy needs associated with either significant weight loss. So really in kids, it's more of like they're failing to achieve standards based on their growth charts. So when they go to the doctor usually will say, well, their BMI looks good and they're in the 50th percentile for height and weight, and they really get focused on that growth chart. A kiddo with ARFID may be like a failure to thrive kiddo. So they're going to present as significantly underweight usually, or with significant weight loss. They will also typically present with significant nutritional deficiencies. So what that means is maybe they're not getting enough vitamins or minerals. They don't have enough variety in their food. And so nutritionally, they aren't getting what they need. Dependence on feeding methods or supplementation. So this could be a child or an adult even who's extremely picky, and because of the lack of variety that they're taking, they may need to be fed or rehabilitated nutritionally through the use of a feeding tube or some kind of nutritional supplement. And then the DSM also highlights that there needs to be marked interference with psychosocial functioning. So what that means is generally someone who qualifies as having a psychological disorder will usually have problems in many domains, if not all domains of their life. So somebody with really bad picky eating or disordered picky eating will see an impact when they're trying to go and be social. Maybe they skip the birthday party because they know they're not going to want the cake and pizza. Or maybe they eat beforehand or always have to pack their own food wherever they're going. And that just kind of makes them seem a little different because it's not as easy to fit in because the picky eating is so extreme that they're not willing to even try the food, even though all their friends are doing it. So those are examples of just how it can impact someone's life. The DSM also specifies that, the avoidance or the restriction of food intake doesn't have anything to do with food availability or any kind of environmental, concern in terms of food availability, pretty much. And then it doesn't occur with body image or a fear of weight gain as part of the disorder. So what that means is avoidant restrictive food intake disorder still has a lot to do with a fear of eating and a fear of food, but not necessarily due to a fear of weight gain or because someone's trying to change the way they look. There are usually 4 different categories that someone would be in if they had ARFID. Some researchers and some authors will say 5, but what I've done over the course of just working with clients is really pare it down into just 4 categories to understand it easily. So those subtypes, the 4 that I'm talking about, the first one is just a sensory food aversion. If someone is averse to food because of sensory issues, it can look different for all different kinds of kids. They can have sensory issues due to not liking the texture of a food, being really sensitive to the way something smells or tastes. They can be really sensitive to different things, sensory in general. So I'm going to spend a little bit of time here because a lot of times when I talk about ARFID and sensory, a lot of parents or other colleagues will ask me if someone has to have autism in order to meet criteria for this. And although sensory aversions and sensory sensitivities are very common in individuals with autism, there are a subset of kids and adults that I would just say are sensory kiddos or sensory people. So what that means is they're just extra sensitive, and not necessarily with all 5 senses, but maybe with 1 or 2 of their senses. And they maybe have always been that way their whole life if they're an adult, or if they're a child, you'll see it kind of show up in different ways. So when I'm doing an assessment and I'm trying to find out, what is the extent of someone's sensory sensitivities, I'm going to be thinking about things like, are they really sensitive to the way tags feel on their clothing? Do they not like to wear certain pants and prefer shorts? Is it really hard for them to walk barefoot in the grass? Is it challenging to have water splashed in their face? Or do they get really sensitive, like with loud noises, such as the toilet flushing or a lawnmower sound or something like that? So I'm going to kind of really try to feel the parent out if it's a child assessment and get some really good understanding of just the early years of development. Typically, if a parent's coming to me, their child is very young already. If they're suspecting picky eating that is beyond just something the kid is going to grow out of. And that's another thing I want to say. A lot of times parents will hear from their pediatrician, don't worry about it. Let's just monitor it for another year or at the next well visit because kids grow out of picky eating. Or if your child is a picky eater, as long as they're eating enough of what they like, I'm okay with that because they're still growing. Those are typically things that I say to parents, if you're hearing that from your pediatrician and your gut feeling says otherwise, you need to listen to your parenting instinct. Because ARFID or very picky eating can eventually just become a pattern that becomes very ingrained and becomes a lifelong problem. And so just so, I can put this out there, I treat children, adolescents, and adults with ARFID, or picky eating, right? And the adults that I work with will say, my parents never did anything to help me with this. They might recall like some traumatic events or stressful events when they were younger, in terms of family dynamics being really tense. So they might say things like, my dad or my mom used to make me sit at the table and wait me out until I ate everything on my plate. And after 2 hours one night, when they just realized I wasn't going to do it, they finally let me go to bed. But everybody was stressed and I was crying and it was super upsetting. But the fact is that no matter what they did or how hard they tried, I wasn't going to eat that food or whatever they were putting in front of me. And so this is like the typical story that I usually hear when families come in about picky eating. That it's gotten so extreme that, they've fought all the fights they can fight. They are not going out to dinner anymore as a family. They're not trying to eat together anymore, or mom or dad is a short order chef to the point where they're cooking something separate for everyone in the household just so the kids will eat. They're not, visiting restaurants anymore, or sometimes if they are going out to eat, it's only to certain places because they know the child will only eat, one type of chicken nugget from one restaurant, and it has to be the restaurant on that certain corner in town. And that's how specific it can get. The other types of specific ARFID tendencies I see are, really brand specific. So kids will only stick to certain brands of chicken nuggets or chips or crackers or whatever it is. Or certain fast food places. So if it's, I only eat the chicken nuggets from Chick-fil-A on the corner, but if mom tries to get me the chicken nuggets from McDonald's, I'm not going to eat them. Or even if it is the Chick-fil-A that I normally get my chicken nuggets from, if they don't look right that day, or if they don't, or if they take too long to come to deliver the order or whatever, then I'm not going to eat them either. And so there's all these requirements that have to be met in order for the child to even eat the food. That's very common with ARFID also. So by the time families do come to me, they're at a place where they've heard from the pediatrician, your child will grow out of this one day, but maybe they've never grown out of it. They are usually at a place where their child was eating maybe 10 to 15 foods, but now the child is only down to like 3 or 5 foods, or they've seen their kid, eat certain foods and then move away from those foods and then cycle back to them and then move away and then come back. So like it's constantly changing what the child will eat, but it usually stays within the few 5 or 10 foods that the kid has. They're definitely at a place where they're no longer going out to eat anymore. And family dinners are usually, survival mode. Families are just doing what they need to do to get by. They're no longer fighting the issue. They've decided to drop the issue because they realize it's kind of out of their hands and they need more help at this point. So back to the sensory food aversion. All of that to say, back to sensory food aversion, right? It can be one of those reasons why we see all those things I just went over. Kids and adults can be just kind of a sensory kid, okay? And I say that for the adults too, because usually they had sensory sensitivities in childhood, but the parents didn't realize it was a real thing. And a lot of times I'll even talk to parents who will say, I didn't have empathy for it. I just thought it was them being stubborn or being disrespectful. And I didn't realize like this was a true struggle that they had and needed help with. The other types of sensory aversion that I can see with kids with ARFID is what a speech therapist who has specialty in oral motor strength and sensitivity would call super taster. So this term is for somebody who truly experiences flavors in a much more intense way than just the average person. So if they're eating something that's sweet, they're going to experience it as much more intensely sweet than you or I would. Or same with sour or spicy. And so that experience can be so overwhelming for someone who's young, first of all, and can't really say what's going on with them, that they don't like it. They don't want to do it again. And so they'll avoid that experience again because they don't know how to really make sense of it. Other families will say, well, my child will eat anything sweet. It doesn't matter what it is as long as it is sweet, but all the other foods or flavors I'm not able to get them to eat. That could be a super taster situation. It could just be a comfort zone situation where a child finds comfort in those types of foods. But in that situation, I always need to have, more team members as a part of my assessment. So I usually will lean on a speech therapist who has expertise in feeding and eating disorders, because that type of speech therapist is going to look at the child or the person a little bit differently than like the average speech therapist. So someone with feeding and eating experience will want to understand if the child has sensory issues, has oral motor strength issues, has oral sensitivity issues, because that can be really important information for me as a psychologist working with a child who has picky eating in terms of knowing what is realistic in terms of expectations for this child. If they don't have the strength in their mouth to even chew certain foods, I'm not going to expect them to start with those types of foods. And usually if a kid hasn't had a lot of experience with a good variety of food, oral motor strength can be in question, and we need to assess for that. So anytime a sensory food aversion is a part of the picture, I'm going to be asking those questions also. For kiddos with sensory food aversion, if they complain about certain textures or certain smells, or, I just met with a child the other day who said, I'm a visual eater. And so what that means is he decides based on how something looks if he's even going to put it in his mouth. So the entire assessment happens visually, and that really determines how he's going to move forward. That is a child who's very much in tune with his sense of vision, right? He's very visual, and he's processing information that way. So depending on whatever's going on with the child from that sensory aspect, we may also recommend that they get an occupational therapy evaluation, because the OT is the provider that can diagnose a sensory integration disorder. And if that's what's going on with the kid, usually it means that they're having a lot of difficulty processing sensory information in the world. And because they're kids, they don't really know how to deal with that or ask for help or explain what's going on with them. And so it can cause a lot of anxiety. And when people get anxious, even kids, it's easier to get through life finding ways to control situations rather than like just going with the flow. So in order to cope with anxiety, a lot of people will try to find a lot of control or ways to feel in control. And when we see that play out in ARFID, avoiding and restricting food intake can be a really big part of how they find control. To stay with only what's comfortable for me, to only eat what I know is not going to upset me or cause some kind of sensory overload. And even though everybody around me thinks I have a problem or it's causing stress in family dynamics or I'm hurting myself nutritionally, this is how I get by right now. This is how I deal with all the anxiety I feel because I'm having sensory integration issues. So there's a lot of treatment that goes with that in terms of helping a child, understand and a family understand first what's happening with this kiddo. And if it's an adult, almost like working backwards. So With adults, I have to really explain everything that I just said in terms of sensory and sensory integration and how it can impact anxiety and anxiety, how that manifests in terms of trying to find control, especially around food. And then working little by little to help the family and the support people really understand not to push someone, not to force them to eat, but to work with what we know about sensory issues and gradually expose somebody to eating more challenging foods. So sensory food aversion is complicated, and I could sit here and talk about it all day long. But the ARFID protocol, or the treatment that I do, I see sensory food aversion quite often. I usually will work very closely with a speech therapist and sometimes an occupational therapist, and treating the person holistically. So looking at, anxiety management, looking at nutritional rehabilitation, having the dietitian, the speech therapist, the occupational therapist, and then me, the psychologist, doing all the different therapy that needs to be done. With my treatment protocol, the expectation, the rate of success really is that in about 8 to 12 weeks, an individual can have the skills and the understanding necessary to start eating food again. And usually with my approach, children and adults are able to integrate at least 3, if not up to 10 or 12 new foods into their repertoire by the end of the 12 weeks that they work with me. And so it's very successful. It's doable if they're appropriate for outpatient, of course. And if you've seen any of my other episodes, I talk all about that. The other ARFID subtype that I want to talk to you guys about is called post-traumatic feeding disorder. And so if someone becomes a picky eater to the point where it's impacting family dynamics, it's threatening their nutritional status, and they're starting to not grow anymore, their failure to thrive kind of kiddos, they have low energy, whatever is going on. So it's causing a lot of problems at this point. It can be because someone experienced a traumatic event around eating. So the examples here are usually if someone chokes on food or has a vomiting experience. Some extreme examples of this that I've seen, was a child who ended up hospitalized because they became so malnourished because they watched a cartoon where they saw somebody throwing up. And so it didn't even happen to them, but because the child was so young, about 5 years old, and they watched a cartoon character throw up, they started to fear that might happen to them. So we call that like a vicarious trauma. They experienced the trauma through watching it happen to someone else, and then they became very scared of that. For that reason, they started to avoid and restrict their food intake to the point where, parents were left not really knowing how to intervene or help, and the child needed a feeding tube to rehabilitate nutritionally and medically. And then over time and therapy and all the interventions, learn how to orally feed themselves again through eating food. Another real life example I've seen of this is a family that I worked with a long time ago, whose child was whose child essentially developed post-traumatic feeding disorder as a baby. So the mother was advised by her maternity nurses to pump after every time she nursed her baby. And because she did this, her body started producing much more milk than the baby actually needed. And so it was like double production of milk. And every time the baby latched or nursed, the baby would get a letdown that was extremely fast and just too much, more than what she actually needed. And the baby would have a choking experience every time she nursed. Well, over time, the baby started throwing up every time she fed. And then over time, as she transitioned to solid foods, would continue the throwing up after every time she ate. From a psychological perspective, from a very, very early age, from being first born, this child associated feeding and eating with this vomiting response. And so doctors essentially medically diagnosed her with what's called cyclical vomiting syndrome. She was a failure to thrive baby, meaning she wasn't getting enough nutrition to support growth. And she was just a low energy kind of kid. She was tired all the time and weak all the time. And so I think she was about 6 years old when she came to see me. And at this point, parents had tried everything in terms of feeding therapies and doctors and different therapists and everything they could find. And it had never actually dawned on the parents that this was a post-traumatic feeding disorder. And so, there was a lot of guilt, parental guilt, that I had to help them work through, because they essentially, the first thing is like, I wish I would have known and it's my fault. Those are the thoughts that parents have. And that's a huge part of the therapy too, is like really just supporting the family dynamics and the parent journey, because it's so hard for moms especially. Society believes we should just be able to feed our kids, right? Why can't you just feed your kid, give them something to eat, make them eat? And eating is just such a big deal from even before the child is born. I always say, if you think about what a mom is going through, she has to think about first, feeding her body while she's pregnant and understanding that everything she eats impacts her fetus's development. Then the baby is born, and then wondering if the baby is going to nurse effectively, or how many ounces did the baby drink, or the transition from, milk to purees to solids, and always wondering if the child is getting enough to eat. It's just such a big stressor on a mother especially. And then to feel like they contributed to the fact that this child is struggling so much in life right now is a huge part of the work we have to do in therapy. And so, to continue with the story of this little kid, she ended up doing the ARFID treatment with me. And after just a few months, the family was functioning much better. They were already an amazing family to work with. They were so appropriate, so supportive, and they took all the recommendations and just ran with them. And they did everything, the way that was being recommended. And she ended up growing a few inches in the time that she was with me, having much more energy and eating way more, variety of food than she ever had in her life. And so those are the types of things that really keep me in this field, is just being able to see that transformation and see kids really bounce back. And that's really the cool thing about working with kids and even teenagers and adults, is how resilient people are. As long as you kind of have the correct understanding of what's going on with them. Another ARFID subtype is the concurrent medical condition. And so this is just picky eating secondary to some kind of medical condition. I like to describe this as, an individual who might have Crohn's disease or celiac disease. So there's something definitely going on medically that causes a great deal of pain or discomfort for the person every time they eat. And so even after the medical condition is diagnosed and treated, and even in some way the client has received relief from the medical issue, that pattern has been ingrained. So the association of every time I eat, I feel pain or discomfort has been ingrained. And that fear of eating remains even after the medical condition is treated. And so that's what this subtype is all about. It's really understanding, okay, before the medical condition, you were eating how many foods, and now you're down to just like broth and bread because you're afraid of everything else. We really need to work this out. And then the last subtype is the general food aversion. So some textbooks and research will call this infantile anorexia. I like to just call it a general food aversion. And the reason for that is because I think the word anorexia can be really confusing. So with general food aversion, this is just, maybe from birth or very young age, the individual just shows disinterest in eating. And that's a real thing. It's more rare. But this is, babies who don't really signal that they're hungry, who don't really show interest when they're offered milk or food. And so it's just kind of been a thing that they came into the world with. And so if that's the case, it's really different, the approach that you take with treating someone who has this subtype of ARFID. So I hope that's become really clear now, is depending on the subtype of ARFID or the reasons behind why the avoidance and the restriction is happening, you have to be very selective or specific about how you move forward with treating it as well. So the treatment plan, even though the diagnosis is the same, the treatment plan for all subtypes of ARFID are going to look very different. So with general food aversion, I can give a real-life example. I was treating maybe like a 16 or 17-year-old female who had this condition. So ever since she was a baby, she was just never interested. And if you asked mom or dad, they would just say, it's just always been this way, and we've just never really known what to do. And, with a kid like this, you have to work really hard to help them understand that, food and mood are very related. And so her experience of depression was pretty severe, and that, could have had a lot to do with just years of being undernourished. Talking to her about, it's so important for you to get your hair and makeup done every morning before you go to school, and you won't leave the house until you check that off your list. We need to add making sure you eat breakfast to that list, and kind of taking that approach to find some motivation or find some way to engage interest, because that general food aversion has just kind of always been there. So there's different ways that we treat different subtypes. It's important to know that there are reasons for why your child may be a picky eater. I talk a lot, in terms of development with parents and colleagues about how kids will be picky eaters as just a general part of growing up. And that is very true. And I think that pediatricians, when they do give that comment of, as long as they're eating and they're still growing, I'm not going to be too concerned, that's kind of what they're going off of. They're understanding that kids go through phases, right? And that's absolutely the case. A lot of times kids will learn that, as they become a toddler and in the early years of preschool even, that I can exert control in my life. And they start saying no, and they start becoming more stubborn, or they start becoming more defiant. And that's just really their way of testing out boundaries and exerting their will. So that is a very healthy thing for children to do. When it becomes to the point, though, that it's not just a phase anymore, it's not just short-lived, or it's creating a lot of stress in our family dynamics, and we're making decisions about what we do in our free time based around if or what the child will eat, then we have more than just it's a phase. And that's when I say listen to those gut instincts, because if your child could eat and just eat, they would, and they may really need more empathy, more understanding, and more intervention and more professional help. Now, the other thing I want to go over, just to be consistent with the previous episodes, are medical complications associated with ARFID. I'm not going to spend too much time here, because if you go back into the episode about anorexia, pretty much all those medical complications that are associated with anorexia can also be associated with ARFID. They generally are a side effect of malnutrition, and that's because the child or the adult is avoiding and restricting food intake to that point of becoming so malnourished that they become at risk for medical complications. There's also in ARFID usually a delay or a stunt in growth, and that's if the person is presenting as underweight. What I also want to say here, though, is that someone with ARFID can present in any weight range. So they can be underweight, they can be normal weight, or they can be overweight. The key is that they are malnourished. So if someone's eating, for example, a lot of energy-dense foods, but that's all they're eating, they may present in their normal weight range or even overweight, but they're still going to be very malnourished because they're not getting a variety of nutrition from a variety of foods. So that's the key. So it's really about malnutrition and not about being underweight, where the medical complications come in for ARFID. And so that's it for today. That's picky eating, the fancy way of talking about it, when to really understand it's just more than a phase. And next week I will probably talk about what causes an eating disorder. I know I've touched on it in previous episodes, but I think it's important to keep talking about it. So there you have it. Thank you so much.